Good afternoon. Are we complete? So that we could...
Good afternoon, not yet.
Admitting someone. So that we could have the documentation. Lakshmi, you're in a vehicle.
Ma'am, actually, I'm going to hospital.
But you're not driving? You're not the one driving?
No.
Okay, that's good. Okay. Okay, could you have a screenshot so that we could have a documentation of your attendance? And then Abhishek send to Viber again. Okay, open your screens. Okay, so good afternoon. So we will have our small group discussion on third trimester bleeding. So if we're talking about third trimester bleeding, what are the entities that you have to take note of? What do you have to know? Anyone? Priyal, Gundigara, what are examples of third trimester bleeding?
Ma'am, spontaneous rupture or any accident?
Okay. It could be spontaneous labor. Patient is about to deliver. There would be bloody show. So that could be an example of bleeding in the third trimester. Okay. What else?
Doc, placental abruption.
Okay, placental abruption is one consideration. What is placental abruption?
Preterm abruption of the placenta.
What could be a better, would anyone have a better definition of what abruptio placenta is? Your classmate said it's preterm separation of the placenta. Half correct. Could you improve the definition?
Premature separation of the placenta.
Premature separation of the placenta from
the uterus.
From the uterus.
From the uterus. Particularly where?
Endometrium, doc.
Endometrium, or what do you call that? You call that the uterine wall into your decidua basalis. So that is your abruptio placenta. Okay, what else? What else would be an example of your third trimester bleeding?
Placenta previa, doc.
Okay. Placenta previa. How will you define then placenta previa?
Placenta covering the cervical os or lowing, and laying low in the uterus.
Is it always the case that it covers the internal os?
No, doc. It might lay low in the uterus too.
Okay, because we know that there are different kinds of placenta previa. The one that you're describing is previa totalis, wherein it covers the whole os. It could be, what are the other types of previa?
Doc, partial placenta previa,
Okay,
marginal,
okay,
marginal placenta previa, and lateral placenta previa.
okay. Can you differentiate the types of previa?
Doc, lateral placenta previa will be within 2 centimeters from the os.
So that is low lying, okay.
Yes, doc.
Marginal is?
Marginal is touching the internal os from the just from the side, just from the border.
Okay.
Partial will be, it is incompletely lying over the internal os.
Okay.
And previa totalis will be completely lying on the internal os.
Okay. So knowing these definitions of the 4 types of placenta previa, previa in itself is defined as what? It's placental tissue that is found near or on the internal cervical os. Okay? So what are your other sources of third trimester bleeding?
And of uterine rupture.
Third trimester. Is uterine rupture still considered third trimester? There's another entity but is rarer than the other two. Has anyone encountered what vasa previa is?
Vasa,
Yes, doc.
Okay, what is vasa previa?
blood vessels within the placenta entangled to the baby.
Again.
Blood
So
vessels within the placenta, or umbilical cord, they will entangle to the baby.
Okay, what happens is the cord goes ahead of the baby. So what the presenting part is your umbilical cord and goes ahead of the baby, which is dangerous to your fetus. Okay. What are your other causes of third trimester bleeding? Okay, sometimes
Marginal sinus bleed, ma'am.
bloody show,
Marginal
cervicitis,
sinus bleed.
postcoital bleeding, etc., etc. But if it's third trimester bleeding, always think of abruptio versus placenta. Do you know how to differentiate the two? That's why we will have this small group discussion. Okay. So, for example, okay, so you bring out what you know in regarding your third trimester bleeding as we look at this scenario. Okay, you are at the emergency room. You see a patient, 37 weeks age of gestation. First It is her first baby. Notable in history would be a painless, she is complaining of painless vaginal bleeding. Okay, it is her first baby. Sorry, I read it wrong. Complaining of painful vaginal bleeding. Okay. What would be the things that you would do? You are the attending clerk at the emergency room. Pregnant patient, term, complaining of painful vaginal bleeding. What are the things that you would want to ask this patient?
Maybe due to delivery.
Baby is still inside, so it is not due to delivery. What will you ask?
Doc, we will
What
check.
are the first things that you would want to do?
I would ask if there's any sign of hypertension in her history.
Okay, you check for vital signs, especially noting for hypertension. Okay. What else? Could you mute your one by one, please? What else will you elicit in the history of this patient?
Abdominal trauma.
Abdominal trauma, you would ask for history of abdominal trauma.
Yes, doc.
Else.
Doc, I would ask for how much is the bleeding, like how many napkins.
So you will characterize the bleeding amount. What else
Yes, doc.
would you want to know?
Doc will ask
Color.
patient smokes.
If the patient has a history of smoking, what else?
Alcohol. History of alcohol used
History of
during pregnancy.
alcohol. What else?
Any previous myomectomy?
Any previous myomectomy? What else?
And the color of the blood, what type of color is like dark brown or reddish?
Okay, what else?
Any warning signs of hemorrhage?
Any
warning signs of hemorrhage?
Any warning signs of hemorrhage, such as
Warning signs of hemorrhage with any recurrent bleeding.
of recurrent bleeding, etc.
Yes,
Okay, what else?
Ma'am, we can ask how frequent the uterus is contracting.
Okay, you will ask how often the uterus is contracting. Okay. Are you happy with the questions that you have asked? Any more that you want to answer to ask this patient? None?
Ma'am, mainly any recent history regarding the obstetrical history, mainly.
Recent history. Okay. So upon asking these questions, you learn that the BP of the patient is 150 to 100. Highest BP recorded during pregnancy is 180 over 120. She is currently on methyl-dopa 1 tablet 3 times. Methyl-dopa 250 milligrams, 1 tablet 3 times a day. She has no history of abdominal trauma. What are your other questions? Other History is unremarkable. She is a smoker of 2-pack years. Since she's a G1, no other history. She occasionally experiences blurring of vision, but is waxing and waning. Okay. What is your working impression?
Eclampsia.
Abruptio.
Whole working impression, please.
Eclampsia.
G1P0, pregnancy uterine 37 weeks. Preeclampsia what? You've had your lecture on hypertensive disorders of pregnancy.
Preeclampsia with generalized tonic-clonic seizures.
Have we any mention of seizures? Not yet. None yet.
Sorry.
Preeclampsia. How is
Oxygen,
preeclampsia differentiated given the history?
The patient will have seizures.
Severe features.
Okay. Preeclampsia with severe features. What makes it severe features?
This can also happen in more
Blood pressure over 160.
Okay. What else?
Blurring of
Damage to the end of the
As symptoms, has 160 over 100. Okay.
Proteinuria.
We don't have any labs yet. We're still in the history. We don't even have PE yet. Okay?
Convulsions.
So,
Onset visual disturbances.
so you should have asked any history of convulsion. So that was what you were missing. Because you did not ask,
Epigastric pain.
I did not answer. Because you also did not ask, you could not elicit epigastric pain. What else do you want to ask now? Are you happy? So given this history, what are the things that you will anticipate for in your physical examination?
urinalysis, doc.
Physical examination, we are not yet in your diagnostics. We take it step by step. That is how we do it at the emergency room. That's what we are trying to simulate here in this small group discussion. Don't go, it's the always tendency of medical students. How do you diagnose? Or do ultrasound, do diagnostics, etc. But it's the complete history and physical examination that will clinch your diagnosis. So what are the things that you will anticipate in your physical exam? Okay. Anyone?
Tenderness of the epigastric
Any
region.
abdominal pain, doc?
One. Abdominal pain. Okay. Particularly where?
Epigastric region.
Answer it. Epigastric pain. What is the pathophysiology of your epigastric pain?
The stomach pushed upwards.
Anyone who will have a better answer? Go back to your pathology, your basic obstetrics. 2. What causes your epigastric pain? What is the pathophysiology of that? This is a favorite exam question. It's the stretching of what? Blank capsule. Anyone? Your epigastric pain in preeclampsia is caused by the stretching of blank capsule.
Stretching.
Megana, any idea? It's okay. What is stretching? Epigastric
Liver.
is where?
Elongation.
Yeah, I think I heard the answer.
Liver.
It's the stretching of your
Liver.
liver, particularly what capsule? It starts with the letter G. Gleason's capsule. Who gave that answer?
Doc Gumbar, Mrigakshi.
Okay, good. That very good, Megakshi. So that is your pathophysiology of your epigastric pain. It's the stretching of your Gleason's capsule. All right. What are the other symptoms and things that you will look at your physical exam?
There might be knee
Vision
jerk.
loss.
Again.
There
Vision
might
loss.
be knee jerk.
So you particularly look at your
Knee jerk.
Vision loss.
vision. Okay. You are to do a fundoscopy, and what will you check for? Why is the vision affected in preeclampsia? What will you look for?
Urine output.
What?
Doc, arteries to venous ratio.
Okay, you look at the what is the expectation?
The normal is 2:3.
Okay. What else will you see in your fundoscopy?
The veins and arteries, ma'am.
Okay. The vision changes are usually due to what?
Retinal detachment.
Hypertensive retinopathy.
Your hypertensive retinopathies, which is usually what? Your opta, your hemorrhages, what is that plot? That blood is more diabetic. What is
Due to severe
hypertensive?
hypertension, ma'am.
What is hypertensive retinopathy? How it is described? How is it described? Hypertensive retinopathy. It's the nicking of what?
Macular clearance.
Arteriovenous nicking. Venous nicking.
Okay. So what? So you're expecting it's just the reproductive system. You will see that preeclampsia, hypertension, and your pregnancy disorders will affect all systems. What else is affected in preeclampsia? Okay. Headache, blurring of vision, epigastric pain. Okay. Then we could go to the uterus. What are the important findings that you would have in your abdominal exam? You mentioned
Doc,
it.
tenderness.
Tenderness. What else will you note for in your abdominal PE? Oh, we're in obstetrics now. What will you look at your abdominal exam? What will you look for?
Doc, the size of uterus.
Okay, you look at the size of the uterus. You look at the position. Okay. Aside from that, if you are thinking third trimester bleeding and you have to rule in abruption or placenta previa, what will you take note in your abdominal exam?
And fetal height is equal to period of gestation.
Your fetal height.
And period of gestation.
You mentioned it in asking for the history. You asked for it, and you will verify it through your physical examination. And what is that?
Ma'am, we will see if there is any bluish discoloration on the abdomen.
Why would you look for a bluish discoloration in the abdomen? Maybe you, because?
Ma'am, because if it is a concealed type of abruptio, then it may have bled into the myometrium, and that will
I think you're getting confused with looking at the abdomen and looking at the uterus intraoperatively. We will go to that later, Megakshi. But what you are describing is your Cuvilliers uterus. We'll get back to that. Okay? PPE, abdominal exam. You're thinking abruptio, you're thinking placenta previa. What do you look for in your abdominal PE? You have asked this in the history prior. Even in the normal pregnant patient, you have checked the uterus, you have checked pundic height, you have checked position. What else will you look at the abdomen?
Fetal heart sounds.
Fetal heart sounds. What else?
Any signs of fetal distress?
Okay, your fetal heart sounds will tell you that. What else?
Movement.
What?
Fetal movement.
You will look for fetal movement. Okay. What else? And this would be pathognomonic of one kind of third trimester bleeding. That's why it's important for you to elicit this when you're thinking of, when you're ruling in or ruling out third trimester bleeding. And what is this?
Ma'am, retroplacental clot, if I'm not mistaken.
Retroplacental clot. We will have no means to know if it's retroplacental unless we have an ultrasound. This is just physical examination. We're still at the PE. What do you have to take note of so that could clinch your diagnosis of abruptio? Oh, it's for abruptio. So what is it?
Ma'am, not sure, but contraction, uterus
Okay,
contraction.
what kind of contractions are you looking for?
Painful or non-painful?
Okay, it's your painful contractions. How will you describe the contractions? What kind of
As
contractions
precipitated
are you looking
labor,
for?
ma'am, in which the time interval between the onset of the labor and the delivery is shortened.
So that is precipitous labor. So from contractions to delivery is shortened. But in abruptio, there is some contraction that you call tetanic. So this is pathognomonic of your abruptio. If you have your tetanic contractions, how will you describe your tetanic contractions? Okay, let's go back to the first step. How will you describe your normal contractions of a normal pregnant patient? Contractions every
1 minute, 3 contractions, ma'am.
So in 10 minutes, your patient has to have 3 contractions.
contractions.
Okay, approximately lasting for
50
how
to
many?
60 seconds.
Okay, 50 to 60 seconds. Okay. Your tetanic contractions, by its definition of tetanic, what does it tell you? How is it described? Anyone? Tetanic contractions.
Maybe the contractions which last longer than 60 seconds.
Contractions that will last longer than 60 by definition. Contractions that last longer than 2 minutes is considered tetanic contractions. And if you see that, think abruption. Okay? So what else will we do in our physical examination? What else do you have to look for? Knowing the history and physical examination of the patient so far, will you do an internal examination?
No, doc.
No,
Why
doc.
why won't you do an internal examination in this patient?
Doc, there are chances because there might be bleeding if we are uh, like we need to have double setup in case of placental abruption because if anything goes wrong or if the patient had heavy bleeding, so it will be very difficult to treat.
Okay. So, two conditions that you do not do an internal examination on is any patient that is bleeding that you do not know the position of the placenta because it might be previa, one. So, since previa is one of our differentials, we do not do an IE. Okay. The other is on a hypertensive patient of more than 160 over 100. Why do not we do an internal examination on a hypertensive patient?
Maybe
Okay, your patient is hypertensive. Why do we not do an internal exam? Anyone?
They are also at risk of placental abruption.
Is it abruption that we are afraid of? We do not do IE on a hypertensive patient because we are afraid that we might push the patient into what?
So far away from the breath, from there.
Hypervolemic shock.
What we don't want to happen if patient is hypertensive? What's the most extreme?
Early or preterm labor.
What's the most extreme complication of hypertension in pregnancy?
Eclampsia.
Eclampsia. We do not do an
Patient
internal
may
examination
die.
on hypertensive patients because we do not want to push the patient into eclampsia. Although I've never encountered one, I don't want to see one during my stay, or you don't want to see one during your clerkship. Okay? So never do an internal examination on a hypertensive patient. Okay. Are you happy with your physical examination? Short of doing an internal examination, to do a careful speculum exam. And that is to check if there is previa indeed. Okay. So what's your diagnosis? as we um, do the PE, we learned that the patient has tetanic contraction. BP ranges from 100 to fetal heart rate ranges from 100 to 170. What is your working diagnosis?
Doc, G1P0, pregnant uterus, 37 weeks.
Okay.
Preeclampsia with abruptio placenta.
Preeclampsia with severe
symptoms
rule
and
out
abruptio placenta.
Abruptio placenta. Okay. When you admit the patient, what will you do next? So we have admitted the patient with that consideration. Abruptio. What is the next step?
We'll resuscitate the mother first.
Okay, good. Resuscitate the mother, stabilize the mother. Okay. Hello, sorry. My laptop died. Can you hear me?
Yes, Doc.
Yes, Doc.
All right. Okay. So where were we? So we admit the patient. We stabilize the patient. How will we stabilize the patient? One, we make sure that your blood pressure is stable. Okay, it's 150 over 100. You have a dosage of methyl dopa, 1 tablet 3 times a day. Are you happy with that? Are you happy with the regimen given the patient? Saying that it's 150 over 100, the blood pressure. What would be your armamentarium for hypertensive patients such as this?
Doc, 140 over 100.
Your medications, are you happy with methyl dopa, 1 tablet 3 times a day?
Doc, I think the methyl dopa is safe in the patients who are antihypertensive, because the methyl dopa slows the action, and because the onset of the methyl dopa is slow, and it is a mild antihypertensive drug. So I think labitol is the better in case of any hypertensive drug, any patient with hypertension or any preeclamptic patient.
Okay, is labetal available in India?
In case if yes, but if in case if labetalol is not available, in that first substitute we can give hydralazine.
Okay. Your hydralazine, you could give how many? How do you give your hydralazine?
Doc, I think it is also the same like the 220 mg, but we will start with a bit dose with 20 mg, and we will go on increasing it for every 10 minutes if there are no changes, or if the
So that is
if the
oral. Okay, the preparation of hydralazine here is IV. So it's 5 milligrams IV push. So you could give that up to 3 doses if it's not controlled, and then we go to nicardipine chip. Okay, labetalol is indeed the first choice. However, labetalol is not available here in the Philippines. So what we really do give for hypertensive patients is our methyl-dopa. 1 tablet 3 times a day is the lowest dose. What is your maximum dose? Your maximum dose is 3 grams per day. So you could give as high as 4 tablets 3 times a day to achieve BP control. Okay, so that is for your hypertensive medications. So you have to exhaust your medical options, even reach your nicardipine drip before you can declare that your hypertension cannot be controlled. Okay, so that is your armamentarium. All right. So what else will you do? You stabilize the patient. What else will you do once you admit the patient?
And we will check for the coagulation profile.
Check for
Coagulation profile.
what will you check for?
And we will check for the coagulation profile if DIC is present.
Coagulation profile, okay. You ask for your laboratories to check for what?
Coagulation profile if DIC is present.
If DIC is occurring. So what are the labs that will point to DIC? Vibin. Help from others? What are the labs that you will request for a hypertensive patient? Oh, your favorite part. What are the labs that we request for?
This air coming out of the engine, usually for
24 hours urine protein.
Ma'am, urine analysis.
Ma'am, prothrombin time.
For closed pneumothorax, this may
One by one,
usually for penetrating injury or for
Platelet count.
usually for rare factors for penetrating injury. Penetrating
Although
injuries that
this
are
should
not
have
large
been
enough
done
to
with
cause an open
outpatient
thorax.
basis.
Okay? Meaning, once penetrated, okay, the lungs have been jerked on
that. Oh, thank you. So if you're admitted and you want to know if you have to terminate or not, do cesarean section, or you could wait for vaginal. What are the things that could help you? Preeclampsia. If it's not eclampsia yet, what syndrome is that will tell you that your preeclampsia is severe?
sometimes the
HELP syndrome.
on the lungs.
HELP syndrome, ma'am.
Okay, what is your HELP syndrome?
Once.
Hemolysis, elevated liver enzymes, and low platelets.
Okay. So how will
But some those are actually if not depending on.
If you want to attend a lecture, you could exit this class. Don't do things at the same time. It's unfair for me as your SGD facilitator. It's also unfair to the other lecturer. What is that, Fisho? What's that? What's the other subject? Anyways, please. Okay, have some respect. All right. So help. So what are the laboratories that we asked for? What will tell your liver enzymes? What will you ask for? What are your liver enzymes that we have to look for if it's elevated?
ALT and AST.
Okay, you look at your AST and ALT. Usually, it has to be how many times elevated for you to consider it elevated in health?
Twice.
Twice elevated, AST, ALT. Okay, what are the other parameters?
Serum bilirubin level.
Serum bilirubin, what else?
Low platelet count and increased LDH.
Low platelet, how low is the platelet supposed to be?
Less than 1 lakh or less than 100K.
Less than 100.
Yes.
Okay. If have you encountered the criterias for HELP syndrome? The two criterias for HELP syndrome? We'll go back to that later. LDH. How increased should your LDH be?
Greater than 600 international units. Greater than or equal to 600 in international units.
Good. So your LDH should be more than 600. Okay. Has anyone encountered the two criterias for your HELP syndrome? Yes.
And the most common is the patient will be multigravida female.
Okay. Okay. Maybe this is beyond your scope, but read on HELP syndrome using Tennessee criteria, HELP syndrome using Mississippi criteria. Okay? All right. What else will you do? After the labs, you found out that your fetal heart rate is decelerating. What are your options? You have stabilized the BP, and you are able to and you have given your hypertensive medication. So one is your BP control. What is the other mainstay therapy for preeclampsia? What do you give?
Ma'am, aspirin in between 12 to 16 weeks of pregnancy.
That is, we are at the emergency room. You have already admitted the patient. What will we give? Hypertensive patient, what do we give?
Magnesium sulfate.
Okay, we give magnesium sulfate. And your magnesium sulfate is for what?
To prevent seizures.
Preeclampsia.
To prevent seizures. Okay. To make it clear, that's why we have our medicines for BP control. Your magnesium sulfate will not lower your BP. That's not the main reason why we give your magnesium sulfate. Your magnesium sulfate is to prevent occurrence of eclampsia. That's good. Okay. So how do you give your magnesium?
4 mg
IV or
4
IV.
mg MgSO4 through IV and 10 mg through intramuscular.
I will leave that to you. All right. So what are the side effects of your magnesium sulfate? What are we to be wary of when we give this drug? There are three things that we should be wary of when we give magnesium sulfate. And what are these?
Increased sweating.
What are the side effects of magnesium sulfate? Ate, pasabi nga, may nagme-message sa kanya sa friendly doctors, pasahin niya. Ha, kay Kuya. What are the side effects of your magnesium sulfate?
Ma'am, breathing difficulties.
Okay. The worst is respiratory depression. Okay. What are the other two? What disappears first?
Seizures.
What?
Seizures.
That's already eclampsia. These are clinical signs. One, you're correct.
Loss of
Respiratory
patellar
depression is
reflexes.
one. Okay. Loss of reflexes of your DTRs. Okay. What's the other?
Confusion.
Confusion, that's already at the respiratory distress side. What else is affected? It affects your
Ma'am, heart rate also.
heart rate. What else? You think of
Urine output.
okay, that's good. You look at your urine output, because if it's affected, your urine output would be decreased. So remember the three. It affects your reflexes, magnesium affects urine output, and magnesium causes respiratory depression. Would anyone know the therapeutic dose of magnesium?
mg.
What? Okay, you have a window of 4 to 7 mx per liter. Okay, so remember those things. Okay, so you've controlled the BP, you've administered magnesium, you perform your internal examination, and you find out that it is 8 centimeters, 70% effaced, station -2. What else will you do? What else will you have to do to the patient to assure that this would be a safe delivery?
Epidural analgesia.
What else?
Oxytocin for augmentation of contract.
For augmentation, because nearing delivery. What else do you have to make sure of before you augment?
Is there any bleeding? Or the bleeding is stopped?
Okay. What else? What else do you have to check for?
The condition of the fetus.
Condition of the fetus. How will you check for your condition of your fetus? What test is done?
Presentation.
What test is done? You have your electric fetal monitoring. And what is that? Your electrofetal monitoring tracing. Okay. What are the components of your tracing? What will it tell you?
Fetal heart rate, ma'am.
Okay, one is fetal heart rate. That's correct. What else?
Contractions.
You will see the contractions. What else?
Amount of liquor.
Amount of? So you will see
amniotic.
You will see if there's acceleration and there are decelerations. Of course, if there are decelerations, even if it's 7 cm, non-reassuring fetal status, we do an emergency cesarean section. So My take home here is that even if it's abruptio, even if the consideration is abruptio, there is still room for vaginal delivery. Although if it's far off, we do cesarean section. All right? So if it's cesarean section, your classmate was mentioning Cuvillier's uterus. So what happens is that it has bled into the myometrium, and then your uterus is no longer pinkish but has turned into a bluish color. That also is a pathognomonic of your abruptio placenta. So if you see Cuvillier's uterus, think of abruptio placenta. All right? So what else do you have to look for? So we remove the baby, you look at the placenta. What will you look at the placenta to, again, verify your diagnosis of abruptio placenta? Your placenta would have more than more than how many percent blood clots would be significant? Now, I found one blood clot. Will I tell that it's abruptio already? How many percent would make it a significant finding? Anyone? Anyone else? Okay. So it's 20% significant infarcts. So you could say that it is significant. All right. So how many? So you've done your CS, you saw your Cuvillier's, you saw your placenta. Indeed, it was abruptio. How many days postpartum will you observe the patient?
2 to 3 days, ma'am.
2 to 3 days. Up to a maximum of 10 days. Some, although, would get very anxious to stay at the hospital 10 days. So usually, we just extend it for 2 to 3. That's correct. But up to 10 days, there could be changes in your systemic venous pressure, etc., that will affect your hypertension. Okay? And your abruptio is indeed an obstetric emergency. And if you do not know how to recognize it, it would be fatal for your patient and for your mother. Hence, it's an important entity in obstetrics that you should know. Okay. For next SGD, we will have more on third trimester bleeding, particularly Previa. Well, I'm very happy with your performance. I purposely did not give you the case beforehand, and we just discussed a case as we went along because I didn't want you to, I wanted to see what you really know off your head. And I'm very happy with what you know. You have answered it adequately, although sometimes you still get a little mixed up. But I just want to show you that you know the answers. It just has to be processed so that you know. I know it's hard. We do not see real patients, but this is the closest thing that we could do. Do a simulation case, make pretend that we are at the emergency room, look at situations so that you will know what to do when eventually we do have the opportunity to go face to face. Are there any questions on your end? Are there any? So I think it's clear. I know it's just abruptio. I asked you a lot of hypertension questions and other physical exam questions, but you have answered it also adequately. So that's very good as well. So, of course, when you are in clerkship, We do not have, oh, hypertension is the topic. We only study about hypertension. That's for third years. That's for your lower years. This one, again, we're preventive medicine, we're obstetrics. We look at the patient as a whole. So we do not look at it compartmentalized, okay? So we look at the history, we look at the PE, we look at the diagnostics, and then we diagnose. And then we work from there. We treat the patient and not the illness. Always. All right? So I hope this has been a fruitful afternoon for you. So if you have no more questions, you may leave this call. I am very happy with your performance. Okay?
Thank you, Doc.
All right.